So I would like to welcome our next speaker to our presentation to talk about creating tomorrow today. This is Dr. Taoufik Saadi. He's the Chief Medical Officer and is a consultant neurology at the American Center of Psych and Neuro. Dr. Taoufik, welcome.
Thank you very much, Dr. Ahmed, for the kind introduction. It's my pleasure to be here. So in the coming 25 minutes or so, I'll try to review with you some of the data related to...
I'm sorry. I'd just like to make one, and that this symposium is sponsored by Biologics. I'm sorry.
Okay. Thank you, Dr. Ahmed.
Thank you, sir.
Okay. So this is my disclosure. And this is my bio. Obviously, I'm not going to read it out to you, I'll start off with the mechanism of action of Tecfidera. Obviously, our understanding of Tecfidera had evolved over the years. We know that very well that Tecfidera has both anti-inflammatory as well as immunomodulating properties as well as neuroprotective properties. We initially thought it has one component of mechanism of action, but it turns out that it has multiple through its effect on free oxygen radicals. So there's some effect on the central nervous system as well as on the periphery, working on neurodegeneration, demyelination, as well as on axonal transaction. So clearly the impact of this medication has multiple levels in the pathophysiology of patients with multiple sclerosis. Now let's review with you some of the clinical trials that had led to the approval of this medication, as well as some of the phase 4 trials based on some long-term data on this medication. But before we do that, let me briefly tell you how the drug is metabolized. So the DMF undergoes rapid pre-systemic hydrolysis by esterases, and it's converted to the active metabolite, which is monomethyl furamate. As you know, the drug is approved by the FDA back in 2013, and we have more than 500,000 patients had been exposed to this medication so far worldwide. So the initial approval of this medication had been based on two pills I'll talk about later on, and that was followed by several phase 4 clinical post-marketing trials that gave us some more reassuring data on the safety as well as on the effectiveness of this medication. So the initial pivotal trials, which is the Define and Confirm trials, they both had followed the same protocol, except in the confirmed trial there was an open arm of glatiramer acetate over the entire 2 years of outcome of data. These two trials had been followed by 9 years of extension phase that will lead us to about 11 years of data that we have so far on this medication based on the extension of the initial pivotal trials of the Define and Confirm trials. In addition to that, we have several phase 4 trials, and this is one of them, which is the PROTECT trial, which is basically 12 months observational trials that included close to about 1,000 patients with newly diagnosed MS, those patients with EDSS score of less than 3.5, as well as those who had less than one relapse over the past 12 months. And these patients had been followed similar to what we do in our everyday practice every 3 months up to 12 months. And the primary and secondary endpoint of the trial, similar to what we'll see later on with all the phase 4 trials, they look at the annualized relapsing rate as well as the change in the patient-reported outcomes and the ADSS score. Similarly, in the RESPOND trial, they looked at patients who had suboptimal response to glatiramer acetate and also included patients with newly diagnosed patients with MS, those with less than one relapse in the past 12 months, as well as those with ADSS score of less than 3.5, again followed prospectively up to 12 months of follow-up. They used the same primary and secondary measurements, same as we have seen with the PROTECT trial, looking at the annualized relapsing rate as well as secondary outcome in terms of the patient-reported outcomes, safety, etc. The ESTEEM trials, which is a 5-year multinational prospective trial that included more than 380 sites worldwide. It was, again, looking at patients with newly diagnosed patients with MS, and it was a prospective trial. They looking also similar to what we have seen in the previous two trials at the annualized relapsing rate, as well as patient-reported outcomes, as well as at the adverse effects safety profile of this medication. Now, what about the long-term efficacy of Tecfidera? If you look at the initial pivotal trials, which is the define and confirm trials that included patients with newly diagnosed MS patients, if you look at the annualized relapsing rate, clearly it came in favor of the DMF as compared to placebo, with a relative reduction of the relapse rate of almost 50% in favor of DMF as compared to the placebo arm. And if you look at the long-term extension data or the endorsed trial, remember that trial had continued to follow up these patients up to 9 years after the initial 2 years of data on the define and confirm. So we have worth of 11 years of outcome data on this medication based on the two initial pivotal trials. Clearly, it shows that the initial response that we have seen in favor of DMF had maintained over 9 years of follow-up. Moreover, and for those patients who were on placebo and end up being on the DMF later on, they were able to catch up. And as you can see, with the 9 years of follow-up after they were converted to the DMF. If you look at the 12 and 24 weeks confirmed disability progression, again, that came in favor of DMF as compared to the placebo arm, both at 12 weeks as well as in the 24 weeks of follow-up in both the define and confirm trials. Similarly, with the endorsed trial, where we continue to follow up these patients up to 9 years, we can see the maintenance of that improvement over 11 years of follow-up from the initial enrollment of these two trials. Now, what about the MRI measures? If you look at the new enlarging T2 lesions, as well as the GAD-enhancing lesions, as well as the new T1 hypointense lesions, across the two trials, define and confirm, they all came in favor of the DMF arm as compared to the placebo arm across the three measures, with almost 70 to 80% reduction of MRI measures in the DMF arm as compared to the placebo arm. More importantly, if you look at the rate of whole brain volume loss, again, it came in favor of DMF at 2 years of follow-up as compared to the placebo arm in the define and confirm trial. That effect on MRI measures had been maintained with the endorsed trial, which again, it's a long-term follow-up open label trial on patients with the define and confirm trials, so that measures remain to be stable throughout the years of follow-up. Similarly, if you look at the rate of volume loss, tend to also stabilize over years of follow-up in the endorsed trial. Now, what about what we see in everyday practice? Because at the end of the day, these initial pivotal trials included patients with a special enrollment criteria. Now, what happened in our everyday practice? And that had been summarized in this slide with the three phase 4 trials: the PROTECT trial, ESTEEM trial, and the RESPOND trial. And across these trials, if you look at the rates of annualized relapsing rate 12 months before and 12 months after patient had been started on DMF, in all these trials, you can see a clear reduction in the annualized relapsing rate of almost 70 to 80% in favor of the DMF as compared to the placebo, as compared to 12 months before patients were started on DMF. And that would translate on the patient-reported outcomes, and there are several outcome measures that had been tested in these trials, whether being the fatigue component, or the patient overall treatment satisfaction, or the PDI, which is the depression scores, among many others, including the quality of life. So clearly all came in favor in patients who were started on DMF as compared to patients who were before they started on that treatment. Now, what about those patients who are considered newly diagnosed patients with MS? Remember that the define and confirm trial had included patients with newly diagnosed patients. Similarly, that was the case for the PROTECT and the endorse trial and the ESTEEM, which is a observational 5 years follow-up data on patients newly diagnosed. In these trials, if you look at the define and confirm trials, if you look at specifically at those with newly diagnosed patients, you can also appreciate a significant reduction in the annualized relapsing rate in favor of the DMF patients as compared to the placebo component, with almost 2/3 reduction in the annualized relapsing rate in favor of DMF as compared to placebo. There's also significant reduction in the rates of progression, disease progression, in patients who are randomized to DMF as compared to patients who are randomized to the placebo arm. And with the endorse trial, which is again a 9 years follow-up after the 2 years of the define and confirm, so we have 11 years of follow-up. You can also appreciate the significant reduction of the annualized relapsing rate in those with newly diagnosed MS across the 11 years of follow-up. Similarly, if you look at the rates of progression, that also came in favor of the DMF arm as compared to the placebo arm, especially with several years of follow-up. Now, what about what we see in the phase 4 trials? This is specifically looking at the ESTEEM as well as the PROTECT trial. Clearly, again, if you look at the annualized relapsing rate for those with newly diagnosed patients, significant reduction in favor of DMF 12 months after the patient had started on the treatment as compared to 12 months before the patient had started on treatment with DMF in both of these trials. The ESTEEM trial, which is again a 5-year observational trial, as well as in PROTECT trial, which is a 1-year observational trial. That also reflect very positively in terms of the patient-reported outcomes, and this is several of the patient-reported outcomes had been significantly improved after patient had started on DMF after 1 year of follow-up based on several components, as you can see here summarized in that table. Now, what about for the switchers, for patients who had failed either interferon or glatiramer acetate? As you know from the initial trials, as well as in the phase 4 trials, included patients who had failed either interferon or patients had suboptimal response to glatiramer acetate. And you can see here in the define and confirm trials for patients who had previously failed interferon or who had failed glatiramer acetate, if you look at the adjusted annualized relapsing rate, in both of these trials, there's a significant reduction in the annualized relapsing rate in favor of patients who were randomized to DMF as compared to the placebo arm, and those who had previously failed either of these 2 platform therapies, with a significant reduction of close to about 40 to 45% in both of these trials. Similarly, in patients with phase 4 trials, which again, mimicking what we do in everyday practice. These are phase 4 real-world evidence data. In both of these trials, in patients who had suboptimal response to interferon or glatiramer acetate, and then ended up switching to DMF, there was a significant reduction in the annualized relapsing rate 12 months after patients were switched to DMF as compared to 12 months before patients were on DMF in both of these trials, with a significant reduction close to about 75% in both of these 2 trials. Now, in terms of the summary of across all the phase 4 trials and the real world data, across all the trials, you can see almost 80 to 85% reduction of the annualized relapsing rate across the 4 trials that I'm showing in this slide here. That again reflects very positively in terms of the patient-reported outcomes, where we can appreciate significant improvement across several patient-reported outcomes, being the fatigue component, the patient's overall satisfaction, quality of life, as well as depression scores across all these components in the real-world evidence data. Now, what about if you compare DMF across all other platform therapies, as well as compared to patients with fingolimod? This has been done based on meta-analysis of all the trials that we have so far, despite the limitations of these trials, because obviously it included different population with different inclusion criteria. But clearly, based on that, we can see that the drug DMF is clearly superior to the platform therapies, interferon, glatiramer acetate, as well as teriflunomide, where it has comparable efficacy when it comes to fingolimod. This is what you can see in this slide. Clearly, the drug is superior to the platform therapies and as effective as fingolimod, as you can see in this slide. Now, what about the long-term safety data on Tecfidera? Obviously, the first 2 years of data had come from the define and confirm, and then we have data comes from the endorsed trial that had included patients up to 9 years of follow-up, so have worth of 11 years of follow-up data, and clearly there is no signal of negative side effects in the 11 years of follow-up. So it's similar what we have seen with initial 2 years data on the initial pivotal trials. There is no significant difference between the 11 years of follow-up on this medication as compared to the initial pivotal trials with this medication, with the main side effects being nasopharyngitis, flushing, and headache, similar to what we have seen with the initial pivotal trials with this medication. What about the lymphocytes? Obviously, there's about 10 to 30% drop of lymphocytes, mostly observed in the first year of starting this medication, but then it tends to stabilize over several years of follow-up on this medication. There's obviously a few case reports of PML had been reported with the medication. There is some obviously opportunistic infection. Malignancies were also reported with DMF use, but that was independent of the level of lymphocytes count. What about vaccination?
Dr. Taoufik?
Yes.
5 minutes remaining, sir.
Okay. Well, briefly, as you know, that non-live vaccines can be used for this medication, but there's no data on the live attenuated vaccines. We have one data that came when compared this medication as compared to basically interferon, looking at the live vaccines, and you can see there was no differences in the responder with the level of IgG in patients who had either 2-fold increase of the levels of IgG with the live vaccines in both of the interferon as well as on the glatiramer acetate. Pregnancy, quickly, we have very reassuring data based on prospective analysis of that pregnancy registry that included close to 350 patients, and the rates of spontaneous abortion, rates of birth defects were not any different as we have seen with the clinical trials or on the overall MSN general population. This is based on this registry where it included patients, close to about 350 patients, which was a prospective international observational registry. Obviously, this is the design of the trial that included all patients who had the exposure with this medication, basically, and confirmed the pregnancy. And this is the demographics of the patients that were enrolled. And as of April 8th, we have 345 patients that were enrolled with 351 outcomes known. And there was about close to 300 known pregnancy outcomes. There was 94 live birth with this pregnancy, 6% total fetal loss. And if you look at the rates of spontaneous abortion was 5%, obviously similar to what we see with the MS clinical trials, which is close to about 8%, and definitely less than we see in the general population, was almost close to about 12%. Most of these births were actually full term, with 90% were full term. Most of them had average birth weight close to about 80%, 10% had small babies, and 7% or less had large babies, meaning more than 90% percentile. In terms of birth defects, 3% birth defects reported with that pregnancy registry, which is obviously close to what we see with the overall general population. Overall, there is clearly no safety signal that was observed with that registry. It seems that the rates of spontaneous abortion, birth defects were not different than we see with the general population or the overall MS population in the clinical trials. Quickly, in the clinical case here, this is one early cases with the patient started on DMF. On April, she had numbness, previous history of visual disturbances. Initial MRI showed 42 lesions as well as GAD-enhancing lesions, CSF positive oligoclonal band. Obviously, she has early diagnosis of relapsing remitting MS according to New McDonald criteria. She obviously did not like injectables, so she was offered to treatment on Tecfidera, started on this medication, keeping in mind that she was thinking to become pregnant in the years to come. However, after she started on the medication, she had some GI side effects, especially when she reached the dose of 40 milligram times 2. Then the dose was de-escalated, then re-challenged after a month later. She was able to tolerate the medication. A year of follow-up, clearly there was significant stability in terms of clinical ground as well as on terms of MRI measures, and there was no new GAD-enhancing lesions. Overall, so DMF is approved therapy for the treatment of patients with relapsing remitting MS. It obviously showed some favorable outcomes in clinical evaluations, patient-reported outcomes. The drug has shown its efficacy in with different MS population, including those with newly diagnosed MS. And just to wrap it up, obviously we have close to about 500,000 patients that have been exposed to the medication, with almost close to about 1 million patients' years of experience, 13 years of follow-up. All in all, the drug has shown good efficacy, good safety profile, and good data that it's all came in its favor of its use in patients with MS population with different subgroups. With that, I end. Thank you very much for your attention. I think I finished on time, Ahmed.
You finished with 5 seconds to spare. Awesome. Thank you so much, Dr. Taoufik, for the very interesting and educational lecture on dimethyl fumarate, Tecfidera. So we do have some questions. One question is, what are the side effects of Tecfidera and its severity?
Well, the main side effects that I see in everyday practice is basically GI side effects, mostly cramps or diarrhea. But again, if it happens, you de-escalate the dose, you reduce the dose, and you can always try to re-challenge later on. Occasionally, I've seen some patients who had experienced some flushing, but it tends to be very transient, and most of the patients were able to continue with the medication despite that side effects. Only of my patients had to discontinue the medication due to the severity of flush, but you can always try aspirin as a way to treat flushing. But again, out of my all patients that had been tried on this medication, only one patient had to drop out due to the severity of flushing.
Got it. Thank you. There is another question from Dr. Sudhir Kumar. Thank you, sir, for the interesting presentation. As a senior neurologist, how do you see the advent of newer molecules, for example, diroxymethyl fumarate and monomethyl fumarate? Where do one can fit in Tecfidera?
I'm not so sure if I get what exactly meant by the question.
I don't know. I guess there's like maybe the newer molecules or are isotopes of Tecfidera. I would say that they haven't been studied yet. We don't have large, robust trials. So until we have large phase 3 trials showing efficacy, they're just anecdotal evidence. That's how I would approach this question.
That's the way I see it as well.
Okay. And with that, looks like those were the questions. Thank you very much, Dr. Taoufik.
My pleasure. Thank you for having me.
It's always a pleasure having you.
Thank you.